All right. Hello and welcome back to NeuroClarity, your podcast for unraveling brain science one case at a time. In today's episode, we are diving into a rare yet powerful clinical scenario from the neurology journals Pears and Oy-sters series. This one is titled Arterial Wall Enhancement and Rapid Clinical Progression in Non-Inflammatory Cerebral Amyloid Angiopathy. We'll walk you through a fascinating case, explore cutting edge imaging, and uncover how amyloid alone, without any inflammation, can mimic a vasculitis like picture. Let's get started. Our patient is a 61-year-old man who presented with 1 week of behavioral changes, motor aphasia, and right-sided weakness. Imaging revealed a lobal intracerebral hemorrhage in the left superior frontal gyrus. Initially, it looked like hypertension-related bleeding, especially since he was severely hypertensive, but MRI revealed the real culprit, a chronic occipital hemorrhage and multiple lobar microbleeds. This pattern fulfilled the Boston's criteria for probable cerebral amyloid angiopathy, also known as CAA. But that wasn't the end of the story. 1 year later, the patient developed acute psychosis with agitation. On EEG, there were no seizure activities and CSF was non-inflammatory, but it showed reduced beta-amyloid 140 and 142 levels. Now, fast forward to age 68, a steep cognitive decline occurred within just 6 months. This wasn't typical for CAA, and so the team dug deeper. A repeat MRI showed increased numbers of microbleeds, microinfarct, and superficial siderosis, especially in the frontal lobe. But here's the kicker. A high-resolution vessel wall MRI, that's VWMRI, revealed concentric arterial wall enhancement, a pattern that is usually associated with vasculitis or CAA-related inflammation, that is CAA-RI. So, was it CAA-RI? Was it primary angiitis of the CNS, that is PAC-CNS? To answer that, the team performed the brain biopsy and the results were stunning. The results showed severe cerebral amyloid angiopathy without any vessel wall inflammation. What does this mean? Amyloid accumulation alone was causing the arterial wall to light up on imaging without any actual inflammation. Let us take a pause in here and let us break down the clinical takeaway. First, cerebral amyloid angiopathy is a small vessel disease caused by deposition of beta amyloids in the wall of cortical and leptomeningeal vessels. It typically presents with lobar hemorrhages and cognitive decline. The Boston criteria version 2.0 allows clinicians to diagnose probable CAA based on MRI findings, including lobar hemorrhages, cortical superficial siderosis, and lobar microbleeds, even in the absence of a brain biopsy. Remember, to make a definite diagnosis of CAA, you need a post-mortem examination. Vessel wall enhancement used to be seen as a red flag for inflammation, but we now know it can also occur in non-inflammatory cerebral amyloid angiopathy, likely due to breakdown of endothelial integrity caused by beta-amyloids. This can prevent unnecessary treatment with immunosuppressants or corticosteroids. What are the challenges and the surprises of this case? For the Oy-sters, the surprising perils of complexity includes 1. Cerebral amyloid angiopathy isn't always slow and subtle. This patient experienced psychosis, frontal disinhibition, and rapid cognitive decline. Vessel wall enhancement can mimic vasculitis but without inflammation. So, clinicians need to interpret VWMRI findings in context. Brain biopsy isn't perfect. Inflammation can be patchy, but in this case, the biopsy was taken from an area showing MRI abnormalities, improving diagnostic accuracy. This case pushes the frontier of cerebral amyloid angiopathy diagnosis and management. Here's what's changing. VWMRI might serve as a marker of disease severity and not just inflammation. Arterial wall enhancement in CAA may predict future ischemic stroke even without inflammation, and patients with enhancing vessels may have more microbleeds and greater amyloid burden. We are entering an era where imaging, especially VWMRI, could guide not just diagnosis but prognosis and even patient stratification for future trials. In summary, this case teaches us that the brain doesn't always follow the rules. Vessel wall enhancement doesn't always mean vasculitis. Rapid decline doesn't always mean inflammation, and CAA isn't always subtle. Understanding the nuance of imaging, biomarkers, and pathology allows us to provide clarity even when the clinical picture is cloudy. Thank you for tuning into this episode of NeuroClarity. If you found this case thought provoking, share it, rate it, and subscribe for more mind expanding discussions. Until next time, keep questioning, keep learning, and stay clear. Bye for now.